So today we'll be discussing the elbow and, if time, the wrist. I believe we will have time. I just wanted to mention that I've figured out how to start another YouTube channel and have started uploading the manual muscle test videos that I've done. And I've also uploaded previous class recordings to this. I believe I emailed the link. If you all would give that a whirl and let me know if the link is not working. It's not a public site. There's like sort of 3 levels of privacy. Mine is the middle, where anyone with the link can access it. So this link will remain the same. So has anyone seen it yet?
This is Teresa. I tried it and there was nothing there. It said no videos had been uploaded.
Huh. Okay.
Yeah, it might be a settings issue with me, but it looked like it looked like the page was for me to upload videos. So I wasn't sure if maybe, anyway, I'm just letting you know that it didn't work for me.
I had the same issue, actually.
Interesting. Okay. Well, I will see what we can do about that. I'll try and make it like public, and maybe that will change. Okay. All right. All right. I'll actually work on that during the break.
I actually had the same issue, but then what I did is I typed in your name. I typed in your name, and then videos came up.
Okay.
So I had to search. The link was like Teresa and Jonathan were saying, but then I typed your name in. Videos came up.
This type of stuff is not my area of expertise. I'll tell you, it's like I go to like a tutorial, and like the very first step, it's like that doesn't match like what I see on my computer. So, all right. Well, I'll keep working on that today, and that way you'll have the manual muscle tests and the class recordings to visit. So today we'll cover the elbow and the wrist. Let's see. But first, are there any other questions from previous classes? Okay, very good. All right, so elbow issues are something that I see fairly often. I just, in the notes, which I have uploaded onto the Canvas site, and I've also emailed them to you. So if you have any trouble seeing those, let me know. But there's basically like 3 main terms that you'll come across when you're looking at joint issues, elbow issues: tendinitis, tendinosis, tendinopathy, right? So tendinitis, itis, inflammation; osis, there's some kind of degeneration, usually chronic, usually with no inflammation with the osis. All right. And by the way, Carol, do you have access to the Canvas site?
Yes, I do.
Okay.
Yeah, I saw the notes.
Okay, good. And then you've got tendinopathy, which is like disease. It's usually like often a chronic injury. Apathy usually refers to some kind of pain is involved. Okay, so there's a lot that's been written about elbows and wrist pain. You know, you can go online. There's a lot of books including it. There's a lot of different approaches. So like with the other areas of the body, my attempt has been to consolidate a lot of information and put it together in a way that makes it a little bit more useful and user-friendly, right? And to give you ways of thinking about different approaches, but also including some very simple approaches that can have very successful results. Okay, so in the notes I've included the basic anatomy of the elbow. I've gone over the bones, the muscles that are involved. There's the important extensors. There's the flexors. There's a few other important muscles. I've listed out the main joints that you can see there, and I've talked about, obviously, you know, 6 of the 12 meridians are going to go through the elbow. The main ones that I deal with elbow pain is mostly the large intestine channel, the triple heater, the small intestine, and to some degree the heart, more for the medial epicondylitis, right? Of relatively lesser importance, but sometimes included, is the lung and the pericardium. What I've noticed is that when someone has issues regarding their elbow, you really do want to check out the neck. You really want to examine the neck, like we've covered in the two classes ago. A lot of times, the cause could either be from the neck, the cervical region itself, especially the nerves and the nerve root leaving the spine in the cervical region, or it could complicate an issue with the elbow. All right, that includes the shoulder and the upper back too. If the person has particularly tight levator scapulae, tight trapezius, right? And depending on the kind of work that they do, if they have very physical labor, the pain and the problems could start to spread down into the shoulder area and then down into the elbow and even into the wrist, right? As always, check Akabanis, right? For those of you who are joining us, there's a test that we use involving the Jingwell points at the tips of the fingers and toes, and we wave an incense stick over the Jingwell, or sometimes called Tingwell points, right? These points at the fingertips and the tips of the toes. And we count the number of passes with this hot incense stick, and then we compare left and right, and that tells us about the bilateral circulation of qi through the channels. So make sure you check the Akabanis. Obviously, visually inspect the area. You always want to palpate, like everything. Palpate, palpate, palpate. You really want to turn your fingers on because they're going to give you a lot of information. All right. With the elbow, like the shoulder, you want to also work with the range of motion to check that. I've listed here, again, a reminder about passive movements and active or resisted movements, right? Passive movements is really just test the joints flexibility. These are things that you're moving the patient's arm, you're moving their hand to check their wrist, you're moving their arm to check the elbow. We're going to cover some orthopedic evaluations, many of which involve passive movements combined with some resistive movements. Resisted contractions test for strength and stability of the joint. All right, this is where the patient will resist a particular movement that you're doing, right? A lot of the manual muscle tests are restricted contractions or active movements, okay? So I've also included, just like in every note, just so you have it all together, there's your basic assessments of the sinew meridians, and then your basic assessment of the primary meridians, right, by different evaluation or location of pain. There's some orthopedic evaluations that we'll go over in more detail as we talk about each condition. As I mentioned, if you go online to Physio Tutors on YouTube, Kai and Andreas, I believe is their names. These guys, these are physical therapists who've done a remarkable job at producing some really excellent videos demonstrating various orthopedic evaluations. Highly encourage you to check that out. I've also, of course, mentioned to include here trigger points because some of you, this may resonate for you closely, right? You may really like to use trigger points. It's not something that I include a lot in my practice, occasionally, but more often I've got good success with the strategies that I've been utilizing. But again, Travell and Simons have an excellent book on the trigger points of the upper and lower body. So I highly recommend that. Also, I've mentioned about Usher points, right? Points that, for those of you who don't know what an Usher point is, an Usher means, roughly translated, that's it. Like that's the spot. So you're pressing along an area, right? And all of a sudden, ooh, patient feels pain or sudden discomfort. Ooh, that's it. That's the spot, right? So there's a number of needle techniques that are useful for treating Ashi points to break up any fascial adhesions, to break up any stagnation of qi and blood, also to help stimulate movement of qi and blood through the area in cases of deficiency, okay? Generally, I do a gentle lift and thrust. If it's a very hard, resistant, it feels like an excess under there, then I'll generally do a lift and thrust technique with an emphasis on the lift to kind of draw out any kind of pathogenic factors that are obstructing the smooth flow of qi and blood. And I'll leave that in for about 15 to 20 minutes. If it's very empty and overly yielding, right, we need to tonify. So I may do some lift and thrust with an emphasis on the thrust to kind of bring qi more to that area. And I might leave that in from like 5 to 10 minutes. These are also good points to do e-stim on, electric stimulation, right? And then I've included some just some general extra points. I've included some Master Dung points, as well as some links. There's a really nice website. Let me see if I can share my screen. So there's this really nice website associated with eLotus. Can you see this? Okay. Yeah, so it's masterdungacupuncture.org. It's associated with eLotus. You can go and click, like, so finding the master tongue points, right? So, you know, they've got them divided up by the different areas of the body, right? So we're, you know, maybe dealing with the upper arm or the forearm, right? And then it gives you like a nice list, and it tells you like here, oh, this overlaps with a traditional point. And you click on it, and then there you go. And then some of them, like this one, for example, has a really nice little video on needling it. It's a wonderful resource, right? So it's part of eLotus. It's masterdungacupuncture.org. Okay, so you guys can check that out. Right, really nice. I really like the videos. Not every single point has a video on finding it and needling it, but a lot of them do, and I thought it was really, really well done. All right, let's see.
That's really cool, actually.
Yeah, yeah, I think so too. I just kind of stumbled across it, and I was like, "Oh, this is gold. This is great." All right, so I've just included a number of Master Dung points that are really incredibly useful. I'll talk about how to integrate those points in treatment in just a moment. So I included some points for the lateral elbow, and I included some points for the medial elbow, as well as some other points that I've listed here, large intestine 11 and so forth, and then some opposite elbow points on the opposite side, opposite Ashur points, as well as the channel balancing points a la Dr. Tan, right? So, you know, elbow is treated by knee and vice versa. I will say, though, that I have found the treating points on the elbow for the knee seems to be a lot more effective than treating knee points for the elbow. I've gotten a lot more bang for my buck by treating like the opposite elbow. So if I have like, you know, right lateral epicondylitis pain, often points on the left elbow that relate to this. So maybe this is involving the triple heater primary meridian. Then I would go to like the pericardium channel on the other side. That seems to give me more bang for my buck. I don't know why. It just seems to do that. So I don't have any data to support it, just experience. So there's there's sort of 4 common conditions regarding the elbow. I've included a few of them here. One is tennis elbow or lateral epicondylitis, or the other is golfer's or thrower's elbow. And that's the medial epicondylitis. There's also medial collateral ligament sprain or elbow sprain. Sometimes that's referred to as thrower's elbow, as well as osteoarthritis, okay? Obviously, there's a number of conditions that involve the elbow. A very common one is simple trauma. So when you're doing channel balancing with the primary channels, right, there's anything that's involving a limb, anything that's involving extremity, is mirrored, it's called, then you would use the mirror format. So like arm treats leg, leg treats arm, right? So shoulder connects, balances and is balanced by points on the hip, right? Upper arm, thigh, elbow, knee, forearm, calf and shin, wrist, ankle, hand, foot, right? Fingers, toes. What I have found, so obviously, like if I have a pain in the elbow, using the mirror format, I would use the opposite knee, right? Because the elbow is the fulcrum of the leg. I mean, the upper extremity, the knee is the fulcrum of the lower extremity. But what I have found is that there's a lot of channels that are, like, let's say I have a problem with the triple heater channel, right? that goes along in here, right? I got like a lot of pain, or let's say large intestine, right? I got like large intestine pain, like going along here in the elbow. It's really bad, like right along the lateral epicondyle and, you know, just a little bit anterior to that. So obviously large intestine is Han Tai Yang, Han Yang Ming. So that would be balanced by Foot Yang Ming, which is the stomach channel. So then I would go to the opposite knee around the stomach channel. So, you know, large intestine 11 would be kind of represented by stomach 35. Again, this is a channel balancing strategy, not a point balancing strategy. What I would do is I would look to the opposite elbow, and I would either look to maybe same meridian, different limb. So I might look to large intestine Ashur points along the opposite elbow, or I would look to points like that, say, balance it in another way, like say, for example, large intestine via system 3 is balanced by lung, its elemental interior-exterior partner, right? So then I'd be looking around the area of lung 5. So you could do same meridian, opposite side, or you could do, you know, the other channels that balance that meridian on the opposite side. And what I've found is that treating the other elbow, either same meridian or balancing meridians, has a better effect than points on the knee. Okay. All right. So I've given you a little link for some information about tennis elbow, technically called lateral epicondylitis. Has anyone ever had this? Well, that's good. Okay. All right. So this is a pretty common injury or condition that results either from some kind of trauma or some kind of repetitive stress, repetitive motion that wears down the joint, creates inflammation, right? It most often involves the extensor carpi radialis brevis, extensor carpi radialis brevis. And what happens is anybody who has any kind of like, especially among athletes, the forearm motion where there's a lot of like bending and twisting at the same time, like tennis players. I mean, we just watched, maybe some of you watched Rafael Nadal tie Roger Federer's record for a number of men's titles. He beat Djokovic, who thankfully didn't hit anybody, hit any linesmen with his tennis balls this time. But anyway, so you see them, you know, they put a lot of spin on the ball, right? So they're doing a lot of this motion, they're doing a lot of that motion, right? So any type of gripping and twisting, especially with some kind of elbow flexion, you know, you're torquing, right? These muscles that attach to the lateral and sometimes medial epicondyle, right? So this is an area of pain that's usually found like right over the area. It's generally not very mysterious, okay? So the lateral epicondyle is this bony protuberance on the lateral aspect of the elbow, and a lot of muscles attach here. And later on in the notes, I've given you some lists of, or early in the, I think it was earlier, muscles attach. Let's see, was it earlier? Yes. Yes. And what I've also included on your notes is just in this section, but it's also on Canvas. It's also in another document on Canvas, relating the sinew meridians with different muscles. So this way, when you test for a sinew meridian evaluation, and you say, oh yeah, it shows up with bearing weight, right? Large intestine, or twisting and rotating, that's triple heater. You can then say, okay, then I suspect these muscles, these individual muscles might be involved. Let's go and do a manual muscle test. And let's also, you know, palpate along that muscle area for Ashur points, for muscle knots, right? That may not be sore, but, you know, to you feel very hard and unresilient, okay? Does that make sense? So it's just another way of like, kind of like backing up and putting in some redundancy to ensure a more refined assessment and diagnosis, okay? So I've explained to you a little bit about what tennis elbow is. It's basically a breakdown of these muscles that attach at the lateral epicondyle. There's often pain, so that's tendinopathy, okay? The supinator, there's also like something called supinator syndrome or radial nerve entrapment, which is a little bit different, but can result in pain in this area, right? It will also include weakness, which can also be one of the symptoms of lateral epicondylitis. And with lateral epicondylitis, you might also get this like weird paresthesia sensation, right? Like this numbing, vague numbing sense that might kind of radiate outwards from the elbow. And some of these symptoms overlap with the supinator syndrome or radial nerve entrapment. So there's a really nice way of differentiating lateral epicondylitis. If the paresthesia and the weakness, if the paresthesia and the pain also radiate down to the wrist and there's weakness in the wrist, fingers and thumb upon extension, that's generally indicating that it's more the nerve entrapment. Now they can occur simultaneously, especially if there's been some kind of trauma. Someone falls, they go down, they hit their elbow. You know, if anybody of you watch football or soccer, the other football, you know, when they hit the ground, a lot of ways they stop and brace themselves is by landing on their elbows, okay? So over time, this repeated trauma can impact and damage the tissue and create a lot of inflammation, which then entraps the nerve, which results in these symptoms, okay? But more often than not, the lateral epicondylitis, more often than not, will have a slow onset. It will be a gradual onset at the lateral aspect of the elbow joint. It may or may not radiate down the forearm. Generally, there will be a history of one-sided trauma or overuse, okay? And again, this repetitive motion that requires contraction, gripping of the fingers and the wrist extensors, right? Engagement of the wrist extensors, as well as prolonged strain on these forearm muscles, right? Combined with maybe exposure, right? People work outside or they work in indoors in conditions like maybe they worked at like a meat packing plant, or you know, they work in a store where they have to go into a cooler frequently, right? Or they're in and out of different environments, okay? So, but generally there'll be some kind of gradual onset and maybe some history of trauma that at the time, maybe it wasn't a big deal, okay? So you wanna palpate around the area to locate the tenderness. You wanna locate the primary meridians involved. You wanna then do your movement assessments for the sinew meridians, okay? You may also wanna say, okay, well, based on this sinew, I also want to look for these external pathogenic factors. So for example, if you suspect the small intestine meridians involved, right? It hurts like with extension, right? Reaching out. And you also palpate and it looks like the small intestine primary meridian might be involved, right? You do certain assessments. Small intestine is Taiyang. That implies the possibility of wind-cold involvement, okay? So then you want to look for signs and symptoms of wind-cold, possibly on the tongue, certainly on the pulse, and maybe other signs and symptoms as well. Aversion to wind, aversion to cold. It feels better when it's I apply heat. It's worse with cold. Like barometric pressure changes really affect it a lot, even when it's not like rainy necessarily, right? But the pressure goes up and down, like today, right? It's not raining right now, but we're in a low pressure system, right? So maybe that, you know, with the temperature changes and barometric pressure changes, right? That implies like wind, and then Taiyang specifically is like wind cold. Maybe you suspect a triple heater, so then you say, well, I wonder if it's wind damp. Right? So you look for signs and symptoms of wind damp on the tongue, on the pulse, right? Is there like much of a thicker coating on the tongue? Is the pulse more slippery? Or does it separate more at the moderate level? Obviously, is it worse with damp, rainy weather, right? That often is sometimes improved with heat and worse with cold. And then maybe you suspect the large intestine channel, and that would imply wind heat, right? So is it better with ice? Is it better with cold? Is it worse with warm temperatures, right? And so forth. Is the pulse rapid, right? Or maybe a flooding pulse, okay? So these are ways of assessing. Again, I'm giving you ways of like not just going, we don't want you to just go by like one bit of data. We really want to build a very strong case, like you're taking this to court, like, Your Honor, I suspect, triple heater, primary and sinew meridian involvement, and this is my evidence, right? Because that's going to ensure better results with treatment. All right. So there's a couple of different tests that we can use to assess, right? And I just want to show you. So by the way, this is what my channel looks like. So I have to, maybe it just says your channel. So I'll look at that. So for example, let's see, what is it? Mills test. Let's do the Mills test. Share my screen here. All right. So can you guys see this list of tests on your screen?
Yes.
Okay. All right. So you can go to Physio Tutors. Oy vey.
This is going to be a video on the Mills test for lateral epicondylitis, better known as tennis elbow.
Very exciting music.
Hi and welcome back to Physio Tutors. The Mills test is designed to maximally stretch and therefore provoke the extensor carpi radialis longus and brevis. To perform the Mills test, have your patient in standing position and fixate the humerus while you palpate the lateral epicondyle. Then passively pronate your patient's forearm, flex the wrist, and extend the elbow fully. This test is positive if your patient complains about sudden pain at the lateral epicondyle. Okay guys, this was the Mills test for lateral epicondylitis.
Okay, so that's the Mills test. All right. Again, you can see really good production values on those. So there's also the Cosen's test. Let's take a look at that.
For over 45 years,
Oh, for Pete's
Nutrisystem
sakes.
has helped millions of people
Oy,
and live
I hate my dad.
delicious prepared meals and snacks delivered right to your door. And right now, you can save
All right.
50% on a month of meals, plus get a week of probiotic shakes to help support your immunity free. We're here for you. Get free home delivery.
You can't see
and
me, but
stay
I'm sitting here
healthy with
tapping my foot.
Nutrisystem. Click now to get your plan. 50% on a month of meals delivered to your door.
Oy.
So we can see you, but we can't see your foot.
All right, let's see if I can get out of this nonsense. There
This
we
is
go.
going to be a video on the Cosen's test for lateral epicondylitis, better known as tennis elbow.
I have a 10-second dance party here.
Hi and welcome back to Physio Tutors. The Cosen's test is designed to maximally flex and thus provoke the extensor carpi radialis longus and brevis. To conduct the test, have your patient in a comfortable position and stabilize his elbow while you palpate his lateral epicondyle with your thumb. Then ask your patient to make a fist, pronate his forearm and radially deviate, and extend the wrist while the examiner gives resistance. This test is positive if your patient complains about sudden pain at the lateral epicondyle. All right, guys, this was the Cousins test to test for tennis elbow. If you want to check out other videos.
Okay. All right. All right. So that combines, you know, some simple resistive movements. So what may be hard to see in that video is because Andreas started lifting his hand up before Kai put his hand down, is you want to, when it's pronated and ulnarly deviated, like pulled in, then put your hand down, then have them lift up, right? So that's the resistance, and that'll put a lot of pressure on this lateral epicondyle here. Okay, does that make sense?
Yes.
Okay, great. All right, so there's also the extensor digitorum test. This is when the patient extends their elbow and their wrist and their fingers. Basically what I've said in the notes here, in a neutral position, you put that out in front of your body. All right, and the practitioner basically pushes down on the middle finger, right? So I actually want you to try this. So just like hold your arm out, right? And then sort of with some resistance, resist pushing down on your own middle finger. Does anybody feel some discomfort here?
No.
Not anymore. Used to all the time.
Yeah, right. That's right. Yeah. Okay.
No,
So, yeah, this is like a really simple test. This is often the test I do first because it's so simple. And to me, like the order in which I've listed the tests, Mills, Cousins, and the EDC resistance test, like to me kind of tests for chronicity. You know, the longer someone's had the pain, again, this is not scientific data, you know, this is just in my experience. You know, the Mills test is like, okay, it's pretty recent. The Cousins test, yeah, it's been like pretty chronic. And then the extensor digitorum, like people who've had it for a long time, you know, they're going to be really sensitive to these tests. So, you know, that's why it's so nice. And it's so simple. Like, you know, you just sit someone down and they're sitting in the chair and you're talking to them about their elbow. And I just say, okay, hold out your arm. And I say, okay, you know, resist my downward pressure with your finger. And they're like, ah. And so it's such a, like an immediate and dramatic example of a test that really helps to establish like rapport and you know, credibility that you can kind of, and like, it's almost like magic. Like you're just doing this, like this simple movement and people are like, wow, okay, yeah, right. So this is a really good test to do. I often do that first while they're in the chair. You know, it's very simple. And, you know, obviously if they're in the chair and you're near a table, you can have them do the Cousins. You can have them stand up and do the Mills test. Okay. All right. So in Chinese medicine terms, sorry, does somebody have a question? Okay. In Chinese medicine terms, tennis elbow is generally classified in a couple of ways. One is using the classical language, sinew channel taxation or sinew channel damage, right? Or it's wind-cold invasion of the elbow leading to cold settling in the joints, right? And that's more of like what we would call like B syndrome, where there's wind, cold, and damp. All three have to be there for B syndrome, but one will be predominant, either wind or cold or damp. So more often than not, both are there. Because again, remember, the sinews circulate the wei qi, the yang qi. So if there's sinew channel damage, that leaves the area susceptible to exposure. So what normally might not affect, you know, these thermal stressors may not normally affect a person. If the sinew channels are damaged, the wei qi is weak, and that kind of like opens gates in the wall around us that allows these invaders to get in. Okay, so more often than not, they show up together. The treatment strategy, of course, is to invigorate blood because over time there's going to be some blood stasis. Definitely to move qi, right? So move qi, invigorate blood, move blood, what's called free the network vessels. So you're allowing the proper circulation of qi through the sinew channels, as well as the circulation and flow of qi through the low vessels and the primary channels, right? And of course, you want to warm cold and expel wind, or if there's damp, expel or resolve the damp. And of course, to relieve pain. Relieving pain is generally like removing the toxic influence of the pathogenic factor, breaking the blood stasis. But we put that in there because in terms of other treatments that you'll do in addition to needling and moxa, relieve pain will imply the use of certain poultices or liniments or other techniques like gua sha, right? Or channel balancing, right? Okay. So I've listed a number of different treatments and kind of like in the order in which I generally do them. This seems to respond extremely well to sinew meridian treatments. So again, there's different stages of sinew meridian treatment. What I would encourage you to do in the beginning as beginners is to include at least the Jingwell point. So let's say the worst pain, right, is upon twisting, right? That Cozen's test, boy, that really set them off. And you have them twist the arm at the elbow. Again, young sinew meridians are tested with the arm or leg straight. Boy, that really sets them off. Bearing weight is kind of sore. Maybe that's like a 4 out of 10, 5 out of 10. Twisting is like a 7 or 8 out of 10. Maybe the extending the arm, that's maybe like a 3 or 4 out of 10. So, generally in my experience, if the patient is not coming in from a trauma within like a few days, after about a week, to some degree, all the sinew meridians are going to be involved. Again, these merge and overlap over the area. This is like an area of circulation, right? So over time, the issue the external pathogenic factor and the damage can spread to affect the other sinews. So this is why I highly recommend, you start with the Jingwell point of the most painful sinew channel that's associated with the most, or the sinew channel associated with the most painful movement. And then you do the gathering point. So interestingly enough, when we're dealing with lateral epicondylitis, we're dealing with one or more of the 3 yang sinew channels, and they all have the same gathering point, which is this area between like gallbladder 13 and small intestine 8 on the head on the same side, right? So in a way, when you do this gathering point, you're actually including and influencing all 3 of the yang sinew meridians. So this is why it's very responsive to sinew meridian treatment. And again, the sinew meridians, there's the most superficial level. They primarily affect the fascia, and the fascia, when that's healthy, the muscles slide over and under the fascia much more easily. So the fascia kind of contain the muscles. So when you relax the fascia and heal that, it makes it easier for the muscles to perform in the way that nature intended. Does this make sense? Right? Because if you work primarily with the primary channels and you're working mostly with Ashur, the muscles, and the blood and of the low vessels, and not dealing with the fascia, the muscles then kind of like are able to relax and free up, but they're still held tight by the fascia, which inhibits its movement, which is what the sinew channels allow us to do. They facilitate movement. So they do and certainly influence the muscles, but they also primarily affect the fascia as well. So that's why I love the sinew meridian treatments. I get a lot of good results from that. And then you can go back and include either Ashur points, or you can include G-clef points along that channel. Something that I came across in Machocha, he's got a book on the channels of acupuncture, cleverly titled Channels of Acupuncture. And I came across this little thing where he talked about combining the low point of the like paired elemental meridian on the opposite side. And I'll get into that in a minute, right? But basically you'll do the Jingwell point, the gathering point, then go back and palpate along for Ashur points. You can do points above and below, right? That are either named and numbered points, or areas that you palpate and find Ashur, you can do above and below. Again, if it's really tense, tight, hard, maybe even like it feels like a knot, you can do the lift and thrust technique with an emphasis on the lift and then retain. You can also go back and include G-clef points, right, to help break through that blockage of accumulation in the channel. You can, and by this time, the patient's going to be feeling better. And then you can also supplement with either like low vessel or G-clef points. Let me just look at my notes real quick here, because the notes I've got here are a little bit different. Yeah, so I wanted to make a little note here for you that are in your notes, but not in my printed ones. So pathology, this is just above the, on page 4, just above the 4 most common elbow conditions. I wanted to point out this note that pathology in the sinew meridians will usually manifest with feelings of stiffness and hardness upon palpation. So you're palpating along the sinew meridian trajectory. It's generally going to feel kind of stiff and hard. And when they're affected, it's usually going to be pain when they're gripping something with their hand or gripping and twisting. In chronic cases, right, again, the patient's been exposed to some kind of pathogenic factor for a period of time that breaks down substance, particularly blood. It inhibits qi. So the muscles and the fascia are not nourished, and over time will become flaccid and weak, right? So that said that they're in a state of emptiness. So you have to do points to build blood, nourish blood, you know, blood building points systemically, AEPs with Moxa, local points, like the low vessel points, especially with Moxa. If there's a lot of stagnation, you can bleed the low junction points. But the sharp or intense pains in the elbow joint, and people will often say, you know, it's like, it's kind of achy and sore, but boy, I'll move in a certain way, or I'll grip something like a doorknob or something, and for a flash, I get this really sharp pain. So they get this like dull, achy pain punctuated by like this intense, brief, sharp pain, maybe even electrical pain. That indicates low vessel involvement, all right? So more often than not, on the lateral side, it's large intestine, right? Posterior, it's more often triple heater, and of course medial, it's more often the small intestine. And so you want to include points that involve this. So one of the things that you can do is include points. Let me see if I got it here. Yeah. So I just have to look this up for a second. See if I have it. Maybe I don't have it on the ones I've uploaded to you. I thought I did. But basically what you would do is you can needle. Maybe I put it in the other one. Let's see. So what you can do is basically, if the large intestine's involved, and I suspect low vessel involvement because there's these occasional sharp pains, what I can do is I would do the low junction point on the affected side on large intestine, which is large intestine 6. And then I would do the junction on the opposite arm for the paired meridian. In this case, it would be lung 7. Does this make sense? So if triple heater's involved, and they occasionally get these sharp pains, and I suspect low vessel involvement, I would do the low junction point on triple heater, which is triple heater 5, right? And that's yin-yang pair is pericardium. Then on the opposite side, I do pericardium 6. Does this make sense? I get one nod. Okay, very good. So this is a way, like, and if you think about like the way we, correct Akabanis, right? The one that's slow to respond, we start with the junction point, right? So this helps, I think, balance the yin-yang aspects of things. I just started experimenting to see if like how it is by doing the junction point on the same side. It's been hard to distinguish for me in terms of like, oh yeah, now that's the, like usually the effect is very subtle because I'm also doing other things at the same time. But there is a nice pulse change. I have noticed that when I include the low vessel point on its interior related official, like so triple heat, cardium, large intestine, lung, right? There is a decent pulse shift. So that tells me something important is happening. That tells me that the qi in blood is circulating better. Right? So I just want to throw that in there. I discovered that just kind of recently, and I've read through that book a couple times. So I like each time I've missed it. So that was interesting. All right. So again, depending on the meridian that's involved, it might imply external pathogenic factor involvement. Taiyang is wind cold. Shaoyang, wind damp. Yangming, wind heat. So if there's more of like a Yangming issue, that might imply wind heat involvement, and therefore you might want to do gua sha, like, lubricate it up and do gua sha, not over the area, because that will hurt. But if you do gua sha over the muscles, like just past like the tendinomuscular junction onto the muscles, and you gua sha away from the area, right? That can really be beneficial. Taiyang involvement, small intestine, then you might want to do moxa right on the area, maybe even moxa needle, right? Needle into the joint, or into the joint through small intestine 8, right? And then do moxa on the needle to bring heat into that area, or direct moxa, very nice, okay? And obviously, you're going to apply liniments that have the appropriate thermal effect. So if it's wind cold, I'm going to be doing very warming liniments. The exception is if there's still a lot of pain and swelling and redness or inflammation, or if there's been trauma and there's still a little bit of swelling and it's still within like the week, then I will assume that there's some internal heat from the damage from the trauma. And so on those, I would actually, in the beginning phase, I would consider it stage 1 of traumatic injury, I would do Ditdat Jiaos that are more cold in nature, right? Like the trauma liniment, right? These are very cold, blood stasis breaking herbs, heat clearing herbs, right? Very cooling, okay? To reduce the inflammation, which then helps to reduce the swelling, right? And break blood stasis. And, but what you can do is then apply more warming liniments to the muscles of the area to enhance the circulation through there and warm any cold in the muscles. So you could do a cool trauma liniment, Ditdat Jiao, over the area, right? Like, let's say small intestine area in here, right? And then in the muscles, you can do like a more warming, like tendon lotion type stuff, okay? And of course, if you haven't gotten to the point where you're like, relieving the pain as much as you would have liked, then you can include extra points like the Master Dung points I've mentioned. Start with the opposite side. Just do 1 or 2 of them. Just do 1 or 2 of them. And that should really be all you need. And if you don't like the master dunk points, you can do channel balancing points, which is basically like, easiest one is same spot, opposite side, right? Or system 3, right? Interior, exterior relationship. So if it's small intestine, I would do heart on the opposite elbow in the area of the pain, right? If it's, large intestine, you're doing lung. And if it's triple heater, you're doing pericardium, okay? So that's a really easy way to treat medial epicondylitis, all right?
Fine.
So questions?
Yeah, this is Teresa. I have a quick question. Could you repeat or tell me where to find it in the notes, the correlations between the 6 division pairs and the heat-cold invasion?
I think that's in the assessment and diagnosis essay.
Okay, early
That's
on.
Canvas.
Okay, all right, thank you.
Yeah. Why don't we take a short break? Carrie is going to join us, inshallah, at 10 o'clock. So why don't we just take a brief break? I have 9:54, so we'll come back in about 6 minutes. Okay, take it away.
Hello, everyone. I'm Dr. Carrie Westhauser. I'm the director of the Chinese Herbal Program. Thank you, Time, for letting me last minute. Well, I guess we were told to do this, so thank you to the USU and all the powers that be at MUIH. Time was very agreeable, and I am literally going to jump in and give the briefest talk ever recorded on Chinese herbal medicine as it relates to elbow pain. I will probably repeat a little bit of what Time has said, but I'll do it very briefly, right? Real briefly. But again, this is in no way exhaustive. It is barely scratching the surface, but just to give another nod to modalities, as I think I heard a student talking about that, there's a reminder, there's other modalities out there for us to help our patients. Okay. I am going to share my very brief PowerPoint. Hold on.
Thank you for putting this together.
You're welcome. Very, very, very brief PowerPoint today. I am very briefly going to talk about and touch upon, maybe that's a better way to say it, touch upon the 2 models of understanding pain, or what we call Tong, okay? Hold on one second. So obviously today we are briefly touching upon the Chinese medical model, and we are touching upon, hold on one second, I'm also getting this page movement here, hold on. We're briefly touching upon the Chinese medical model, which talks more about relationships and interactions, the linking of the body systems through channels, collaterals, passages and pathways, tissue function and structure, and what we would call B, or what Time has probably referred to as painful obstruction syndromes. And then we look at the anatomical model, the biomedical model, which is, structure and function, understanding biomechanics of the musculoskeletal system. And obviously each system has their advantages. In the anatomical model, the precision with which we can identify a pain-causing structure is amazing, right? MRIs, CAT scans, our ability to be very precise, it's fantastic. But where it's lacking in the anatomical model is the relationship of the parts to the whole. As we know, as acupuncturists and herbalists, we're looking at the whole mechanism, the whole being. As we know more about Qi and blood and all of the functions of normality and disharmonies, we know a lot about Qi and blood stasis and wind and all these terms, and damp, which bring us into what we know as B syndromes. So there's advantages and disadvantages in these systems. Hold on one second. For some reason, my clicker is not moving to advance my slides. Hold on. There we go. So again, very briefly, B syndromes, I think I heard Time mentioning we have topicals. So we can put plasters and poultices and ointments. Obviously, I'm pointing to elbow because today is focusing on the elbow. We utilize tuina, liniments, and mobilization is very key for us as we treat our patients. This helps us assess, and it also gives us an understanding of tissue structure and function. Acupuncture, we all know about that, which includes our cupping and our heat therapies. And then today, what I will spend a little more time speaking on are Chinese herbal internal decoctions that we take for disharmonies. So those 4 bullet points are really how we manage and deal with B syndrome. And as you know, as that relates to biomedicine, we talk about numbness, stiffness, pain. If we go into biomedical terms specifically, we talk about arthritis. We speak of nerve compression, degeneration. We speak of inflammatory conditions. And so all these 4 bullet points here are where the acupuncturist herbalist should spend their time with utilizing multiple tools. As we bring something specific into an elbow, which is, I know, today's topic, we have to either administer topicals, plasters, poultices, ointments, or liniments, because when we administer an internal herbal decoction, we have to bring the herbal decoction to a specific musculoskeletal place. And this is, again, if we're not utilizing acupuncture, which of course we can. The way herbal formulas are constructed is obviously different than the administration of an anti-inflammatory or an analgesic in biomedicine. When we put together an herbal formula, we are thinking about flavors and flavors being utilized to specifically address the type of pain. Is it mobile? Is it fixed? Is it stabbing? Is it aching? Et cetera, et cetera. Is it numb? Is it radiating and moving? Does the elbow or compression or degeneration cause numbing or tingling? So we're using flavor in herbs. Real quickly, we talk about acrid, which is like a pungent flavor, like a garlic. I don't mean to say garlic as the herb, but like to give you an idea of what acrid is. Bitter greens would be a very quick nutritional idea of what bitter tastes like. Sweet, not the sweet of candy, but the sweet of like an almond or a fig. Bland, what you would imagine, a very blasé flavor. And then of course our herbal formulas have a warm to hot or a cool to cold nature. If I see an elbow and it is, let's call it tennis elbow for this moment, and it's like stiff and red and hot, I'm not going to be using in my decoctions, my herbal formulas, herbs that are too warming, because I'm seeing a redness, an inflammatory response of a redder nature. If a patient reports that it's very weather affected and it's like, oh, when it's cold and damp, oh, so then I would want to be using warming medicinals, warming acrid mobile medicinals. So I'm giving you the very, very briefest blip on herbs I can to just say, we wouldn't administer a more generic here's a formula, or here's a liniment, or here's a topical or an ointment that is just for an elbow. We know it will help with what we call B syndrome or these inflammatory conditions. We would get very specific to the temperature, the flavor, and the exact description of the type of pain. When we speak of elbows, it's a lot of compression, radial tunnel syndrome, overuse syndromes, right? A lot of elbow disorders. I have a lot of patients in my practice who are golfers. I call them racket sport players, where they're overusing the joint. Sometimes it's radiating and causing a problem down to the fingers and hands, numbness, tingling, etc. But when we use herbs, all the different kinds, we're using flavor and temperature to choose the specific action. When we talk about on the hand on the slide, the pharmaceutical actions, when you look at a formula, when we speak in biomedical terms, most of the formulas for B syndrome or pain syndrome are anti-inflammatory chemical constituents. They are analgesic chemical constituents. And the one formula I'm going to speak of today, which I'll show you next, has 217 chemical components in it. Can you imagine when I show you the formula and it's only between 8 to 10 ingredients, and there are 217 active chemical constituents, in addition to which the one I'll show you has 70 target protein acting qualities, acting on all sorts of pathways, from the lipoprotein pathways I'll show you the list, but it's unbelievable when you take a sort of a lens and look at a Chinese herbal formula in a very different microscopic way. There are so many chemical constituents, it's really actually hard to define which of these constituents is actually the most effective, which I'll show you next. So I'm just going to bring up this one formula today as I do this very brief lecture. This is a very, very commonly used formula called Huan Bitang. Most of the acupuncturist herbalists know it well. Remove painful obstruction decoction. It sounds very, very important. It's one of the most widely prescribed formulas. It's like a base, like what those ingredients there say to you, even though we're not going to go into each one of the ingredients. Those items together are a base formula, one of the most widely prescribed, reliable therapeutics for pain, mostly located in the upper parts of the body. So we use this formula a lot for neck, shoulders, arms, and of course, today's topic, elbows. As we modify this formula, adding and subtracting, this is where the acupuncturist herbalist would be looking for and analyzing mobility, asking detailed questions about temperature, what kind of pain, achy, stabby, burny, all the things probably time has mentioned to you. Onset of disorder, was it a quick acting thing? Was it a slow, insidious type of pain that came because you kept golfing and kept golfing and kept golfing, right? The majority of the ingredients in this formula from a Chinese medical perspective are mobile. So they are moving blood and qi in the body, specifically, again, the upper. I heard Time mentioning different acupuncture points and liniments or like topicals. To bring an internal decoction to a location, we would add either an acupuncture prescription protocol, or we would add a topical to bring the formula to a specific place, since Huan Bitang is for the upper, most effectively, again, neck, shoulder, arm, and elbow. So I'm not going to go through these ingredients. That's a whole nother thing to go through, but think this is more for a fixed type of pain, more for a weather affected type of pain, where a patient will say, gosh, that elbow is getting more stiff and achy as the weather is damp or cold, et cetera, et cetera. So these are herbs that are acrid, mobile. These are herbs that move blood and qi very well. And for those of us who know the concept of wind, these herbs scatter wind in the tissues. So wind, very briefly, as we all know, describes sort of a movement, so a slight radiation. So wherever this pain is, it has a little bit of movement. And so we use the concepts of mobilizing blood and qi to move out the old blood, bring in the new blood, and regenerate tissue. Reduce inflammation if we decide it's a hot condition. But obviously, if it's a colder condition, this specific formula you see here is very warming, acrid, wind scattering, and blood and qi moving. Just for fun, I took a snapshot to show you what some of the herbs look like. The herbs are all very different. They all grow in different regions. They're all harvested at different times. They all have versatile therapeutic properties. But when you put a prescription together, the prescription becomes one energetic pharmacological thing, even though, like I told you earlier, as you take a microscope to herbs, you find they have hundreds and hundreds of active chemical constituents and many, many things they target, proteins, lipids, etc. So this is why when we speak of Chinese herbal medicine as Chinese practitioners, we speak of their flavor, temperature, and their energetics. And when we look at them from a biomedical lens, we see it's quite a rabbit hole, hundreds and hundreds of active chemical constituents, most of them being of an anti-inflammatory nature or an analgesic nature. The last thing I'll say before I wrap it up is that there are interactions, meaning if a patient is currently taking corticosteroids or immunosuppressants from their Western physicians, those two classifications of Western drugs will interact with, let's say I'm showing you this one Formula One Bitang for the elbow, they will actually deactivate many of the properties of, let's say, this type of a formula, a B syndrome formula. So when let's say we have a patient and they have tennis elbow and we decide this is it, this is the best formula, and we'll give them a topical and we'll sprinkle in some acupuncture. Very, very important to find out, are they already on any type of steroid for their musculoskeletal condition? Unrelated, are they in a, let's say, a rheumatic arthritis condition or a psoriatic arthritis condition where they're taking an immunosuppressant? Those two classifications would actually deactivate. And so as a practitioner, we'd say, gosh, why isn't my formula really working so well? Those two classifications of drugs will deactivate many of the properties of this formula. So I know that was very brief, quite a blip look at B syndrome and also at herbal medicine, the many, many applications of herbal medicine. But I hope it was slightly eye-opening, and if anyone has any questions, I'm happy to answer them.
No questions?
All right.
Well, that was great. Thank you so much. And that is a fantastic formula, actually.
Yes. Hopefully you can speak to it more in your class. And I know time goes over topicals, et cetera, et cetera. So very nice to see all of you. Thank you for hopefully the USU students, again, it's just more information on the many tools we have in our toolbox to help our patients.
Nice. Thanks again, Carrie.
Take care. Bye.
Thank you so much, ma'am.
Thank you, ma'am.
Okay. All right. So, yes, she's an excellent teacher. I'm actually taking her herb program as well. So I'm also a student in her class, and she's very good. So I'd like to just briefly go over golfer's elbow, and then we'll take more of a break, more of a real break. And then we'll go over a little bit with arthritis, and we'll talk about the wrist as well. And then hopefully I believe we'll have time to go over some maybe rehabilitative exercises. All right, so anybody ever have golfer's elbow or medial epicondylitis? Well, that's good. Okay. So I've found that lateral epicondylitis is a little bit more common than medial epicondylitis. With medial epicondylitis, like lateral epicondylitis, a lot of people who lift weights in the gym, but people who are not weight lifters will often injure their elbows either on the lateral side or the medial side. The reason why I say people who lift weights as opposed to weightlifters is weightlifters are people who are like, they're almost like, you know, major or minor league weightlifting, right? I mean, they're in the gym every day. It's not just a hobby. It's almost like part of their life, or it could be, you know, they may be competitive. So these people have a lot more knowledge about mechanics. You know, people who haven't had much training in weightlifting, they're like, oh, I want to get back in shape. I want to go to the gym. You know, maybe they look at a few things online and their mechanics aren't so great. And as their weight load goes up, right? Not, you know, if they're, you know, lifting 5, 10, 15, 20 pounds, not so big a deal. Unless they're doing like, you know, those weights like repeatedly every day, wrong. Or as their weights go up, that's when they really start to injure themselves. So like I said, lateral epicondylitis is a little bit more common, but medial epicondylitis is very common for people who are lifting weights incorrectly. A lot of hairstylists, you know, barbers, you know, they're holding their arms up like this all the day and they're like gripping and moving things. Let's see, yeah, so them, who else? Anyone who's doing any kind of like throwing or pitching motion, baseball players, football players. I'm sure you guys know lots of javelin throwers, right? I mean, they're everywhere. It's very popular these days. You know, manicurists, certain musicians, dentists, carpenters, certainly, you know, with hammers and all kinds of saws and drills. Mechanics who are like, you know, up under a car or a truck, you know, like working hard, you know, with tools and things like that. It may not be dealing with a lot of heavy things all the time, but this like repeated, you know, repetitive strain can wear down the muscles and then the tendons that are attaching to the medial epicondyle. All right, so one of the things you want to differentiate is, again, this type of like ulnar nerve entrapment. And the way you can do that is called with Tinel's signs. So let's say here's my medial epicondyle, here's my olecranon, and then there's that groove, right? The ulnar groove, ulnar nerve groove. So that's really kind of close to where small intestine 8 is, just a little bit distal to that. So what you want to do is you want to find that groove just lateral to the medial epicondyle, and you want to tap that. Some pretty firm pressure. Now you're going to feel some tingling in the local area, but if that tingling or paresthesia radiates out more than like a 1/4 inch, right, or even pain, then, you know, that's a sign that you either have or have the beginnings of ulnar nerve entrapment, right? So then you're going to do the other tests like the medial epicondylitis test, the elbow flexion tests, and that's going to help to differentiate, because if you don't have discomfort or pain on those tests and only the pain and or paresthesia here, then that's more nerve entrapment, okay? All right, so there's a couple different tests that I have included in your notes. Let's see if I can get to those. Okay, I'll try and share my screen. So I found a few tests online. There was this one, I was just like, my Lord, this is the most robotic test I've ever seen done. Let me see if I can share my screen. Hold on a second. All right, can you guys see that? Golfer's elbow test?
Yes.
Golfer's elbow test. Seated or standing, elbow flexed to 90 degrees. Forearm, elbow placed in full pronation. Fingers flexed, make into a fist. Tester stands in front facing the athlete. Places hand around the wrist. Places the other hand under the elbow supporting the arm, palpating medial epicondyle. Passively supinates the forearm through a full range of motion. Passively extends the elbow through a full range of motion. Passively extend the wrist through a full range of motion. Performs assessment bilaterally. Positive finding, pain. Involves structure, medial epicondyle.
Okay. Well, that was exciting, wasn't it? Stand on 2 feet. Place smile on face. All right. And they're doing it like in some back storeroom, the poor guy. They got him in like some like, you know, closet. All right, so that's one test. All right. The other test is like the elbow flexion test, which sounds a little bit like a drag, because like basically what you're just doing is you're just having your patient do this for 5 minutes. Like, okay, sit here and do this. I'm gonna go get some tea, and then I'll be back in 5 minutes. So you can have them do that to see if that recreates the pain in the medial epicondyle. Right. I'm gonna go answer some texts. You keep doing this. And I'll be back. All right, but basically what you're doing is there's going to be some version of get kind of like trapped in my little cubby hole back here. Basically what you're doing is you've got the elbow inflection, right? And honestly, I don't have them go down and then extend their wrist. I have them go like this. You know, I'm palpating the medial epicondyle, I'm supporting the elbow, and then I have them actually extend their wrist and then go down, right? Like that. Or the fingers, you can do it that way too. I generally like doing that better rather than extend and then extend the wrist. You know, it's like sort of like one motion, right? Like Spider-Man, right? That's generally a pretty simple test. Let me see here. Let's look at this one here. Okay, for some reason I was muted. Okay, here we go.
In this video, we're going to show you a quick method to test for medial epicondylitis, also known as golfer's elbow. Hi, and welcome back to Physio Tutors. This test is designed to maximally stretch and thus provoke all the muscles that originate from the medial epicondyle and that attach distal to the wrist. To perform this test, have your patient in a standing position, fixate your patient's humerus, and palpate the medial epicondyle at the same time. Then passively supinate your patient's forearm, extend your patient's wrist, and extend the elbow fully. This test is positive if your patient complains about sudden pain at the medial epicondyle. Okay, this was our video on medial epicondylitis, also known as golfer's elbow. If you want to get to know 2 tests for lateral epicondylitis, also called tennis elbow, check out the Cousins test right here or the Mills test right here.
Okay. Love it. All right. So you see how he actually had the wrist in extension as the arm went down. Okay. I found this to be a little bit better and a better assessment, especially if it's in less severe cases, right? All right. So basically what you're dealing with is very similar to lateral epicondylitis, except it's affecting the structures of the medial epicondyle. The treatment is relatively similar, with a few minor differentiations. Obviously, the sinew meridians that you're going to test for are going to be a little bit different. And then also the primary meridians that might be involved are going to be slightly different. What I've found most often is that heart and small intestine are the sinews and primary meridians that are most involved in this for a couple reasons. One is location, and also the active extension is a Tai-Yang movement. And then also different types of movement like this. This is, I think, like the heart sinew meridian test. So there's a little bit of that movement in there as well. And so this is also a condition that responds really well to acupuncture treatment. It's supported, I think, in herbs. And I definitely, you know, the more I'm learning about herbs, the more I recommend herbs be involved in your treatment, because it's like the patient can get a little treatment every day to deal with nourishing the blood, driving out external pathogenic factors, freeing up the movement of qi and blood through the network and primary vessels and the sinew channels, as well as dealing with, you know, any other issue. So that's really good. Basically, I just do the heart or the small intestine sinew meridian. Again, you want to include the gathering point. So for the 3 yin arm, the gathering point is gallbladder 22. sort of like up into here, all right, in that area. So I would do, you know, the heart jing well, maybe the small intestine jing well, then the gathering point for heart, which is gallbladder 22, maybe the gathering point for small intestine, which is gallbladder 13 to stomach 8 area. And there's a couple other treatments that you can include. One, of course, works really well for the medial side, especially, is the channel balancing. So if it's heart and small intestine involved, you know, you might be looking at small intestine and heart channels on the other elbow, right? Heart is also related also to kidney. So you can try kidney 10 area, opposite side. Again, I've had better luck with opposite elbow than opposite knee, but you can try that for yourself. There's certainly, you can include like the lateral epicondylitis. If you're not getting a lot of benefits or pain resolution or ease of flexibility, or especially if like the muscles themselves, if the muscle knots aren't really going away, in addition to the Usher points, you can do the motor points of the muscles that are involved given the particular sinew channel involvement, okay, which I have included in your notes, okay? So there's manual muscle tests that eventually you'll be able to see, and then you can do those tests, and if they test weak or recreate pain, you can do the motor points for those, and we'll go over motor points more specifically a little bit later on. Just for now, one of the supinator motor points for lateral epicondylitis is a very deep to large intestine 9. So that's a motor point that you can do. You can also look for the medial epicondylitis, some of the flexors. You can do some of these for, I think it's like the flexor carpi ulnaris is probably the primary motor point that is best done. That's in this area right in here. And then also the master dunk points. If the person is experiencing like less muscle knots, like you've got the needles in, and you can go back and treat your Usher points. You know, you can leave these sinew needle treatments in for about 30 minutes. And while you're doing that, you can go back and palpate for Usher points. If you want, you can palpate the G-clef points or the low vessel points, depending on the nature of the pain, and plunk them in, and then go back and palpate along the muscle if it's not too interfering with, if it's not too aggravating of the muscle of the needles that are already in. You can go back, and then with all these other needles in, you can palpate the area for Usher points, and then you can do some lifting and thrusting on those, right? So you've got your sinew vessel points in, then maybe go back, and if it's just achy, dull pains, just maybe do the G-cleft. If there's occasional sharp pains, add the low junction point. And while those are in, just leave those in for a few minutes. You know, then you can go back and treat some Usher points. And that's quite a bit. And that's generally right there a really good treatment. But let's say the patient's, you know, got like a really severe case, and, you know, they need to get back on the job. And so they need to get better, you know, pretty quickly, and they really want to be out of pain, or they've got a lot of pain. You can then add either the channel balancing points on the opposite elbow or opposite knee, or I generally don't do or like some of the distal master dunk points, right? Or go back and like treat some of the motor points of the muscles that are involved, right? And that's like a lot of points, but not too many. And this is generally where I stop, right? So I'll pick either the channel balancing points, either on the opposite elbow or opposite knee, or I'll palpate one of the other master dunk points, just one or two, and see if they're calling out. And if they are, in terms of how they feel under my touch, I might do one or two of those. Or if they're complaining still like a lot of like, you know, muscle stiffness, or you go back and you palpate and the muscles still feel really stiff and hard, then I might include like one or two of the motor points for those muscles involved. Okay. All right. Any questions about that? All right. So just to recap, I generally almost always start with a sinew meridian treatment. because more often, like almost always, that sinew meridian, someone will test positive for at least one of the sinew meridian tests, especially with elbow issues. Shoulder, elbow, wrist, these issues around the extremities, they almost always test positive for a sinew meridian test. Then I'll test out the primary meridians, right? Again, if one of those tests positive, those movements test positive, they're in your notes, then I will start off with like the tonification points. You can do both. You can put the sinew meridian needles in and then primary channel points and then leave those in, and you can have the patient, if it's not too aggravating, you can have them recreate the movements to see if it's any better. It usually is. And then you can, depending on the nature of the pain, maybe include, if the pain hasn't completely subsided, you can include like a G-cleft and or a low junction point, right? And then if the pain is still like, they still feeling it, like you can palpate the area here for lateral, here for medial. If there's still quite a bit of pain, you can have them palpate it themselves, because they're often kind of better at finding the sure spots. Then I may want to do either 1 or 2 channel balancing points, or 1 or 2 master dung points, or if it's still pretty stiff and hard, right, or there's a lot of resistance and muscle knots, then I'll either do like some ashi or some motor points, and sort of call it a day at that. And the motor points, when I treat them, I only leave them in maybe a few minutes. You can do electric stim on the motor points. So what you can do, since e-stim involves a positive and a negative pole, is, the motor point is generally just 1 point, but what you can do is palpate around that motor point before you put that needle into the motor point, palpate around it and see if there's any other like tender or really hard points or like nodules or something like that, or muscle knots. Put another needle in that, and then you can put the positive on the inferior needle and the black on the superior needle, right? And then you can put some e-stim on about 2 hertz, right? 2 hertz is plenty. You can go from 2 to 10, but I would start off with 2 hertz, and you alligator clip them onto the needle shaft, not the handle, and you can just get like a gentle pulsing. So just to the point where the patient feels the pulse, and maybe a little more, not to the point where it's like really intense. Like what I ask my patients is would you be able to fall asleep with this level of stimulation? If the answer is yes, probably, then you're at a good level. But you want them to feel some pulsing. And I'll leave that in like mostly, for the most part, about like just 5 minutes. E-stim is a whole other thing, which I think at the end we'll have time to talk about. But the safe side is, 2 to 10 hertz, up to 5 minutes. You're not going to muck anybody up. Okay. Any questions about that? Okay. And then on your notes, I've included some other distal points. If the neck extensors are very tight, you can certainly do some points, especially if it's like wind cold involvement, maybe bladder 10, wind heat involvement, maybe large intestine 18, wind damp, gallbladder 20, they're all good for wind because they're all up around the neck. And then the appropriate liniments, which we will talk about later in the class, later in the course. Then, after the treatment's done, then I put liniments on there, and it's super nice, right? All right. Any questions about that? All right. So again, when I list the treatments, which are listed, again, your notes are going to be different than mine, but maybe like page 7 and 8. I've listed a bunch of different treatments. Generally, these are kind of like in the order in which I consider them. But again, whatever is inducing the most pain, whether it's a sinew meridian test, movement test, primary movement test, palpation, then that's what I generally treat first, okay? And these are generally the orders in which I will consider the various treatments. I would not include all of these. Again, I really only like to use maybe 6 to 8 points at the most. And so that, because, you know, even if I get like 50%, the patient themselves may not be completely satisfied with that. But as a beginner, I would say, you know, 50% is like, you know, an RBI double. You know, I mean, that's a good treatment. That's a good treatment, right? You know, it's not a home run necessarily. It's not miracle treatment, but, you know, 50% is a big deal in one treatment. So I try not to do too much, 6 to 8 points at the most. And, you know, at different times, you're going to feel drawn in different ways to different points. Like you may get this intuitive guidance to maybe test for and treat trigger points. You know, maybe you're more drawn to like the manual muscle tests and motor points today. But again, you know, I go by results. If this didn't work, I reassure my patient, yeah, I got another strategy to try. Let's try this because of this reason, right? I explain it to them very briefly. And then say, oh, okay, this movement, this implies, you know, there's a meridian of chi that moves through here. And so that implies that this is involved. So let's fix that, okay? All right. Any questions about any of that before we take a break? No questions. Okay. Okay. Well, let's come back at about 11 o'clock. All right. It's 10:42 by my clock. So let's come back at 11, and then we'll briefly go over osteoarthritis, and then we'll talk about the wrist.